Yeah, I know. Where's the Jay-Z at? I need to allow me to reintroduce myself. All right. So last talk of the morning is myself and Tim Baldwin. So I'm going to introduce Tim. For those of you guys that didn't meet Tim yesterday, we did a talk on bracing for knees and hips yesterday. And we're going to do one for you guys today on shoulders and ankles. So a couple of things we learned out this morning. Tim serves as the clinical operations and compliance officer at UCSF in the orthotics and prosthetics department, overseeing all UCSF orthotic and prosthetic clinics. Tim is an ABC certified fitter of orthotics, certified orthotic assistant, and BOC certified athletic trainer. He previously worked in various settings within the orthotics and prosthetics department, including the Orthopaedic Institute, Mount Zion Inpatient, Redwood Shores, and Mission Bay Hospital, providing inpatient and ambulatory pediatric and adult care. He draws on his years of clinical experience to optimize operations and ensure compliance standards are met and exceeded. And Tim and I work together a lot on bracing. And I'm Danny, in case you don't know who I am. And I work at the Orthopaedic Institute as a PT, and I work at Cal as one of the team PTs there. So now you know really who has been making the bad jokes all morning. All right, we're going to talk to you guys about bracing.
We have no disclosures for either of us. And then we're going to skip most of Danny's part and shoulder, as we've learned. He's useless for it, according to Dr. Feely, so we're good there. Bracing is generally a stepping stone. We talked about this yesterday. If you weren't here yesterday, same things. You know, the focus of bracing is usually pain control, stability. It can assist. It can help with activity tolerance, so you can progress. It can give somebody confidence. It can prevent a secondary injury or help reduce the risk of a secondary injury, or it can be prophylactic. But again, they're meant to assist rehab and assist recovery. Most braces, not always, but most of the time, we are actually trying to work people out of their brace. It's used for a time, and it's meant to have a time and a place and then be done.
All right, so kind of general timelines that we like to talk about for bracing. When we look at it from an injury start, we're looking at that pain and tissue activity tolerance issue. So we're going to use this bracing to help with pain and activity tolerance. That's really the focus of it, right? So we're going to introduce it to control symptoms. We're going to provide some external support for the patient. And then we're going to try to just overall reduce those loads on the tissue that's irritable. What does physical therapy do? Again, according to Brian, nothing. But we provide exercises to stimulate support systems that the brace is designed to externally support, right? So we're trying to get them back to that baseline strength, coordination, and stability, and then while still trying to reduce those tissue irritations as well. Muscles reduce injured tissue loads, so that's why we're trying to get the muscles to work better. But muscles work very poorly when there's inflammation and pain. There's a lot of inhibition that goes on. So if we're trying to work through a lot of pain, the classic push through pain in PT doesn't work. So we need to give something to unload those tissues to reduce that pain. And then our end goal is full return back to activity, weaning from the brace. The majority of patients, we're trying to not have them in the brace long term. Every once in a while, you have a few cases where they may need to be in it more long-term, and we'll talk a little bit about that. But trying to return them to those activities and exercise programs as much as possible without the brace long-term.
So for the shoulder, there's actually not a ton of shoulder bracing in general. There's essentially two types, acute injury or instability. That's really the only two things you're going to brace in the shoulder for the most part. Now, as far as acute injury, usually that's going to either lead to surgery or just a limited time of range of motion and pain control that you need to have. So in the top left, in the pink shirt, that's what we call our post-op sling. Essentially, there's two types of post-op slings: an abduction, that's used for most of your shoulder surgeries, or a neutral, which is usually used for more of your humeral fracture surgeries that get a little bit more intense. So there's usually a bolster. There is a simple sling. That's for your patient that came in, they fell on their shoulder, their AC joint hurts a little bit. You try to move them, they almost jump out of the room and kick you in the face because it hurt so bad. And you're just trying to give them something to allow them to just move on. And so you put them in a simple sling, you allow it to calm down a day or two, but you let them know this is temporary. You should only be in this a day or two. Start working your range of motion right after this. Otherwise, you're usually putting them in this abduction sling or this neutral sling post-operatively, or for full tears, full instability, this really locks them in to hold them into those appropriate positions that you're going to have them in. I did throw Sarmiento bracing. It's not technically shoulder, but when you get to the humeral neck and things of that nature, it relates to the shoulder because a lot of people want to sling them because they have a humeral fracture. So humeral fracture bracing, just to give you a basic overview, it's meant to provide circumferential pressure to stabilize the joint through that pressure. Now, the reason why these are very useful is statistically, most patients do the same with and without surgery when it comes to a humeral fracture. Now, this is your average elderly patient that you likely didn't want to have surgery on anyways, and a 25-year-old, you might do surgery more often. But in general, the outcomes tend to be the same of surgery versus no surgery if they meet the criteria that you're hoping, or that they need to meet for that. So, but it provides circumferential pressure. The biggest thing is do not sling them. You don't want to sling them. That's how you're going to give them frozen shoulder. That's how you're going to give them atrophies. It's their arm that's hurt, their shoulder's fine. So we actually tell a lot of patients, which is a huge surprise because they'll come in from the ED in a sling, and you're telling them, actually, you don't want that sling. Bend your elbow. Move your elbow. What does swelling do? Goes down. So if they're like this 24/7 and the injury is proximal to that elbow joint, all that swelling loves to pool there. And then what happens? They get contracted and they can't go anywhere with it. And then Danny really has to crank and sometimes push past pain. So for just understand, for humeral fractures, the large majority, you actually don't want to sling them at all. You put this in this compression brace, you stabilize the humerus, and then you actually have them work basic ranges of motions. Non-weight, you don't want anything in their hand. You don't want to put stress on that humerus, but you do want the motion to continue while that bone heals. And then the other types of shoulder bracing that you can really get into are what are called stabilization braces. So you see these a lot in football where they've dislocated a few times. Maybe they don't want surgery yet. Maybe they aren't a surgical candidate. Or maybe surgery is just later and they want to finish the season. So there's braces out there like the one in the bottom left called Sully's. There's a few different brands and styles of this. Essentially what you can do is pull the straps to reduce either your abduction as well as internal and external rotation depending on how you set the brace. And the idea is you just don't want their arm to ever get above here because that's when they're going to start to dislocate. So it allows them to get back to activity. Biggest downside to this, understand this, no insurance covers this type of brace. Insurances follow Medicare rules that say the definition of a brace is something that fully immobilizes and or is rigid. These are neither. These are assistants to allow some range of motion, just not excessive, so that they don't redislocate or re-injure while they're returning to activity. So understand these types of braces, 100% cash pay, they will never be covered by an insurance. So if your patient asks, let them know, hope you got a couple $100 because that's the only way you're gonna get this, okay? But are they useful? Yes. Can they help? Absolutely. But at the same time, this is like ankle bracing. If you don't do rehab and you don't get the muscles around that area stronger, you are going to continue to sublux, you're going to continue to dislocate, and you're likely going to do far worse injuries to yourself, like tears, like full ruptures, things like that. So they're out there, they're useful, but understand again, they're a Band-Aid like most other braces.
All right, so talking about shoulder rehab with bracing, kind of like yesterday with our other talk, we decided not to put 52,000 exercise options in here for you guys because there's a lot. So I'm just going to kind of break down the basics of what we like to do in terms of following protocols post-op and non-op. So when we talk about protocols afterwards, you really want to be collaborative with your physicians, right? Have those conversations, understand what they're looking for. If you don't have a protocol from them, ask for one. Really make sure that you and the surgeon are on the same page. In a lot of cases, you're going to get different protocols from different surgeons. At UCSF, we have, for the most part, the same protocols, but even every surgeon might have a different idea of how to utilize that. So understanding that is really important. Most of these can still perform passive range out of the brace, right? So a lot of the patients are going to be afraid to come out of the brace. They're going to be afraid that something's going to happen. And just like Tim talked about, if you don't move for 6 weeks, you're going to be very stiff, and it's going to be very difficult to get that range back, right? So we really want to make sure you're moving. The other thing, when Tim was talking about the swelling pooling down into the elbow, that we'll see really commonly with these slings is ulnar neuritis, right? These patients will start to feel that tingling and that numbness in their little finger, and they'll start to get really concerned. Uh-oh, something went wrong. Did the surgeon cut my nerve? And as long as it's not Brian's patients, I'll say no. With him, you never know. But we want to make sure that we're monitoring those symptoms and trying to get them out and moving and flushing that swelling out of there. Okay. Again, slings can really limit motion early, especially external rotation mobility. They're stuck in this internally rotated position and slightly abducted. That's really hard to get external rotation there. So we really want to make sure that they're working on that as well. Okay. In terms of non-op, so we're using braces to support exercises. That's always what we're doing. So we're going to progress from passive range to active assisted range to active ranges, and then eventually loading against resistance. I think one of the things I see really regularly, though, is for some of these injuries that aren't muscle associated, people are afraid to start to use those muscles too early, right? So when I see something like a biceps tenodesis for a slap tear that Dr. Feely was talking about, they still have a rotator cuff that works fine, right? So we need to start to get some load and some activity through those muscles. There's no reason we can't. So make sure that you're looking at that, talking to the physicians, understanding the protocol so that you can start to add some of these exercises early. Don't be afraid when they're in a brace. It's really important. And then again, talking to those surgeons for timelines and precautions. Was there anything else that the surgeon saw in surgery that made them want to stay in this longer? Right? Is there anything that made a change with the type of brace that they used? So understanding why they chose what they chose, was it just basic, this is what I always give? Or was there a specific reason? That's what you want to know. And same thing with fractures. Is there anything about that fracture that I need to know? Is there any other comorbidities with that fracture? Do they have risk of non-union or malunion? What are we looking at in terms of that? So really having those conversations before you start adding these exercises is really, 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 really important. And then again, there's a million exercises that we can do for it. And if you guys have more specific questions, I'm happy to answer those.
And then another thing with the ulnar neuritis to get into before we get into ankle, one thing to ask your patient is show them or ask them to see what it looks like in their sling. If their sling ends at their wrist and that wrist is dipped into ulnar deviation all day, things are going to start to tingle. I don't care who you are. So a proper fitting sling should go to mid-hand. Essentially, everybody's got that line in their palm. Your sling should reach that line in your palm, or it can go further. If it's too long, it's fine. People always worry about how big the envelope is. That doesn't matter at all. That's just extra material. You just want to make sure the elbow is back and the wrist isn't hanging. That's where a lot of those come from. And you can say, hey, scoot your elbow back. They do this, and they're like, my wrist doesn't hurt anymore. Miracle.
Yeah, brace fitment. We talked about brace fitment yesterday with the knees, too. Yeah. So important. And as PTs, understand this stuff. Like, you guys are going to be taking on and donning and doffing, we'll call it, slings all the time, way more than anyone else is. So understand how to adjust them, understand how to find these different things that might be off. And if you need help, contact the orthotist that put that sling on and say, I'm not really sure how to adjust this. What do I do? So make sure you're helping those patients understand that, because the number of times, I'm sure all of you can attest to it. You watch a patient come in and that sling is down here and their elbow is fully extended and they're like, my sling feels weird. You're like, well, it's because you're not wearing it, right? Or the T-scope that's around the ankle, right? We need to make sure that we're understanding how to adjust those to use them correctly. If they have to wear it, let's make sure it's most effective.
So ankle has a lot more. There's a lot you can talk about with the ankle. You can make a whole presentation on just bracing for the ankle. So I'll make it short and sweet, and then obviously we'll have time for questions on this. But for acute and post-op care, your most common things you're going to prescribe are a cam boot. Now, the big question we usually get is, what's the difference between a tall and a short cam boot? And the answer is control. Essentially, the rule is, if the injury crosses the ankle joint, you are 100% in a tall cam boot. A short does not provide enough support for anything that crosses the ankle joint. The short cam boot is for foot injuries, usually fractures. That's when they're usually very helpful for things that don't cross any portion of the foot. The one exception is a Lisfranc. You still need a tall because that tendon runs all the way back through, and people forget that. And a fifth met. Sorry, two rules. And the fifth met because the peroneal runs all the way to the back. But standard is tall, short is only for feet. Or the other times I will fit a short is there are some very short people I will fit, and a short goes all the way up to their knee. Then you're getting enough control. That's when I'll put them in a short when they might have a long foot and no leg length. Okay, a short works because I know how high up that went. But the idea is just to immobilize. They all have a rocker bottom to help with ambulation. And then depending on what you're doing, please tell your patient if they have to sleep in this. It's the number one question we get when we're fitting a cam boot. because that's up to you. We can't make that determination. We might know the answer, but we can't make that determination. So please tell your patient, yes, you are sleeping in this. No, you are not. That helps everybody. If they sleep in it, my number one tip, have them take a pillowcase, put their boot, or put their whole foot with the boot on in the pillowcase, tuck it into the top. It keeps their bed clean, which is a huge concern if they're walking around outside with this. It also covers the Velcro so it doesn't tear their sheets up to shreds. Also works with casting. If you cast a patient in their ankle, use a pillowcase. It saves them money, time, and a ton of stress. Getting down to PFS boots. So these are multipotent and PFS. Really the only indication or the most known indication for these is anytime they have a heel fracture. So when you need to float the heel, there are specific boots that float the heel so that there's no pressure on it. So calcaneal fractures is when we fit these the most. The big rule with these, they're non-ambulatory. You cannot weight bear in them. They're not meant to be weight bearing because you're gonna drive the heel down and eventually hit it. Then you have stirrup ankle braces, your figure 8 ASO ankle braces, your most common things you're gonna use. Again, they're used as a tool to get back to activity. I don't like using them 24/7. Ankle braces are the one brace that if you wear 24/7 and don't do exercises outside of it, you will atrophy and get weaker. That's the one brace that really atrophy takes its toll on if people are wearing this 24/7. There's also rigid ankle braces, which sometimes people want because they want more stability. There's one big issue with these. They create a fulcrum. The top of that brace is usually stronger than the bone that it's protecting. So yes, you might not tear a ligament when you roll your ankle in that really rigid ankle brace, but you're probably gonna break your tib fib. So that's where you have to understand, and the reason why it happens a lot is it's usually on your 6'6" volleyball player that weighs 165 pounds at 6'6". Their legs are this big. That brace is way stronger. So they come down, somebody rolls on them. Yeah, their ligaments are fine, but they absolutely have a tib fib fracture from it. So understand there are benefits and negatives to these types of braces when you go more rigid. Other than that, ankle stirrups is usually what I say for your grade 1s that you just want a little bit of stability, but you're still giving them full range of motion because early range of motion, as Daniel will talk about, is incredibly important with ankle injuries. And then there's custom, obviously, if you have people with long-term drop foot issues, things like that, there's tons of off-the-shelf and custom for that. And then the other one that a lot of people see that they don't know about, there are braces for PTTD, posterior tibial tendon dysfunction. It's an actual ankle brace that you can start with that has a bladder under the foot, and it raises the arch to take the stress off the posterior tibial tendon. It's a great initial to find out, would custom orthotics be a good permanent if you can't get rid of that foot collapse. But it's a way to start to see if it's effective. They can increase, over time they can increase the bladders for comfort, and then you can see if that's helping along with the rehab and everything else they're doing. So that's one brace a lot of people don't know exists, but it is out there. And then there's 100 others that I'm happy to talk about.
Yeah, the PTTD tendon one is the PTTD one is an interesting one, right? We don't see it a lot, but you heard Dr. Luke talk earlier about how rough these posterior tibial tendon dysfunctions can be when they become really degenerated and that arch starts to fall. And so if you get a really bad posterior tib tendon tear and you can't control it and they have a lot of pain, those braces are extremely beneficial for trying to get your patients walking more comfortably, moving more comfortably, and exercising more comfortably. I've had really good success with them, so highly, highly, highly recommend those ones as an in-between. All right, so rehab. Again, there's a billion things we could talk about with ankle rehab as well, but biggest thing, same thing with post-op, understanding protocols, understanding what the actual surgery was, what was repaired, what wasn't, what was done. Read op reports, read op reports, read op reports. It's really important for you to understand what the surgeon did, right? Most, again, can still perform some of this range of motion stuff. We want them to do it out of the boot. There's rarely a case where we're not having them do any range of motion from an early standpoint, okay? In terms of cam boot complications, these are the common ones that we see pretty regularly and why we try to get people out of boots as quickly as possible. So we obviously have low back pain, hip pain, and plantar fascia issues just because you're in that boot for so long. You're not getting normal load through the plantar fascia. You're getting an artificial rocker motion through the boot. So you're not getting that windlass of the foot, that good tension through the plantar fascia. And just like tendons, if they get deloaded and then overloaded or go from a normal load to a heavy overload, that unloading and then loading of the plantar fascia can cause a lot of issues. So making sure that you're really working on foot exercises with these patients, getting some pressure through that plantar fascia if you can is really important. What's the best ankle brace for active individuals from a rehab standpoint? Some of it depends on the activity, but in general, when we're talking kind of non-operatively, the ASO is a great brace. So the ankle support orthosis, it's the figure 8 one that Tim was talking about earlier. Really easy to find. You can find it on Amazon, and they're really good for kind of just general ankle pain issues, general ankle stability issues. So we use that one a lot. And again, we're having patients use it while they're moving around, but we're still doing exercises on the side out of the brace to make sure that we're supplementing that loss of activity from the brace. So the stirrup muscles are the most important there. We're not getting a lot of the posterior tib and peroneal activation when we talk about this ASO. You can get a little bit of dorsiflexion, plantar flexion, but it's really designed to limit inversion, eversion. So making sure that we're adding both open chain and closed chain, eversion and inversion, getting them standing. I see a lot of people put patients on Bosu balls really fast with this. Number one, when we talk about proprioception, there was a study that just came out not that long ago looking at proprioception in Bosu balls on ankle rehab. And what they found was the majority of proprioception from those patients was coming from the hip. They were all doing hip strategy instead of ankle strategy. So it wasn't actually improving anything in the ankle, and it was just making it a higher risk for irritation and injury, right? So we don't need to put people on these Bosu balls. We don't need to have situations like Brian showed earlier of doing squats on a physio ball. Instagram. We just need to make sure that we're focused in these exercises. Sometimes the most basic is the best exercise, right? Basic eversion, inversion activities are really helpful. So don't forget about your basic stuff. To go back to the basics, it's important, okay? Gradually build. In terms of night splints, when are night splints helpful for plantar fasciopathy, right? This is a common question that I get of, I heard about these night splints or these Strasbourg socks. When should I wear it? For me, it's the patients that have that cardinal plantar fascia symptom of pain with the first few steps in the morning, right? If you've got that, if you get out of bed and you're like, man, my foot hurts so bad when I'm walking to the bathroom in the morning, but by the time I get coffee, it's feeling okay, that's a great time for something like a night splint. The Strasbourg socks that pull on the toes, they're really uncomfortable. Patients often won't keep them. So the ones that Tim showed earlier that look more like a cast that have the strap that pulls down, I can go back and show you. Oops, too much. Like the one here on the top right, that's a night splint with a strap that's adjustable. You can adjust the amount of dorsiflexion a bit. Those are way better than the Strasbourg socks that pull your great toe and create a lot of irritation there. So I usually tell patients, find these on Amazon or Walgreens or wherever you get your favorite boot. And then in terms of fully returning to sport, yes, you can use some of these ankle support systems, but just like Tim talked about, you really have to watch out for secondary issues. So knees, contralateral injuries can be an issue where all of a sudden you're starting to compensate. Bony fracture issues in the tib fib can be a big problem. All of these issues. So, Steph obviously has worn his ankle braces every game since he's had multiple ankle surgeries, made multiple ankle injuries, almost took him out of his career, and thank goodness it didn't, right? So he is a big proponent of these active ankle supports when he plays, and he's done really good with it. But if you guys who's watched Steph's training videos ever? Raise your hand if you've ever watched Steph Curry do his training videos. It's unbelievable, right? The guy does so much for his body and so much for his proprioception and control and coordination. That's really why he's doing better. He wears those braces because it makes him feel more confident. But at the end of the day, he's doing well because of all that activity he's done on the outside, right? So it's still important to have that supplement. And then I had to put a picture of Fred Warner because I like to just torture myself. And Bosa right next to him. That was good.
So take-home points. And also with the ankle bracing and stuff like that and doing stuff outside of it. Again, we talked about this yesterday, and for anybody that wasn't here, bracing can't prevent injury. He doesn't wear them because this will prevent him from ever rolling his ankles again. The idea of him wearing them is to reduce the severity of that injury if he were to roll his ankle again. So without all that exercise, without all that strengthening, without everything else, that he can always still roll his ankle. It's just meant to reduce the risk, which is why he only wears it just for those games, just at those high-risk point times. So, understand that there's a purpose for that. But bracing is normally used in conjunction with physical therapy. You heard Brian say it a lot too as well. When we do this with this, that's when you tend to get results. Bracing and PT are the same thing. When you do them in conjunction, they tend to have great results. It doesn't weaken you outside of ankle braces. Like I said, most of these braces are only supporting, they're not supplementing. So that's why, like for the shoulder and things like that, if you're still doing all your normal exercises, the brace is not gonna make you weaker. The Sarmiento requires circumferential pressure. The reason why I bring that up, since I brought up Sarmientos, is very heavy, large, obese patients, you can't actually use these braces on. There's too much soft tissue. You can't create circumferential pressure to actually hold that. Or if they're incredibly swollen still. So if their arm is 3 times the size of their other arm, you likely can't create enough pressure to hold it. So you do have to wait until that swelling goes down for that brace to be effective. Sullies are non-rigid, they're non-covered. So just understand if you're prescribing them, they are a cash pay price only. And then the one thing that we didn't touch on, but is very important, I think you'd agree too, with calf and Achilles injuries, and if they are in a boot, they need to be wedged. You have to start off with a wedge in there for that to heal. If you allow them to be in that boot long-term flat, you have a ton of issues, both with the calf and with the Achilles. So you are always starting off with some level of wedging and then working that wedging out of there, okay? And then rigid ASOs, you can increase that chance of fracture just because it creates a very rigid, strong fulcrum at a midpoint in that shaft, and that's where you can run into those issues. Also, you don't have to go to Amazon for everything. There are O&P clinics you can refer people to that would be happy to take care of this for you.
That's fair. That's fair. All right, you thought we were done, but we're not. We got cases. So we have a 55-year-old female, status post right supraspinatus repair 2 weeks ago. Her current pain is 3 out of 10 at rest with NSAIDs and Tylenol. Her worst pain is 7 out of 10 at night trying to sleep. Her exam shows passive range, 40 dead, 40 degrees of flexion, 30 degrees of abduction, and lacking 5 degrees from neutral of external rotation. So, how long in the sling? What do you guys think? How long should this patient be in a sling? What do you guys usually see? Somebody raise their hand and give me a number. Or just throw it out there. 4 to 6 weeks. I think that was Hannah that said that. Good job, Hannah. 4 to 6 weeks is common, right? We're starting to see this trend of starting to remove the sling a little bit earlier, but classically it was about 6 weeks. So anytime patients are talking about shoulder surgeries and how long am I gonna have to be in this sling, how long am I gonna have to do this, we're generally saying about 6 weeks. So that's kind of the important part. Why? So the reason for this is protective, right? We're trying to protect that repair. It's really important. It's really uncomfortable. We talk about this pain sleeping at night. So odds are this person is either sleeping in a recliner, right, a lazy boy, or they're sleeping with a bunch of pillows or a wedge in bed upright. So it's literally the most difficult position to sleep in long term. But we're doing it so they don't roll over onto that shoulder in the middle of the night. The sling kind of provides that awareness of, hey, something's going on. We shouldn't do a bunch with this. When you start pulling slings early, 3-4 weeks sometimes, you might start to get some reflexive use of that arm, especially if it's the dominant side, right? They start to feel a little bit better around that 4-week mark. The pain's starting to go down. The meds are doing a good job, and they might start to reach and use that arm. I have a patient right now that decided at 4 weeks to take her sling off and try to go swimming because she went on vacation with her kids, and her kids were in the pool, so why not her too? So these are the types of things that you might start to see where these decision-making processes are a little overridden by the reflex. What type of brace? What type of sling, Tim?
So this will be your abduction sling, that basic abduction sling. And the biggest reason is those simple slings don't provide enough immobilization. They really aren't going to hold them in that neutral position that you're hoping for. So they're going to be in that pillowed sling. The other positive to that is those pillows prevent rolling for the most part. So it's a preventative for sleep as well. So that's why you're going to be in that abduction sling.
And then can it be removed, when and why? Yeah, we can remove that sling for exercise, right? We can remove that sling to do passive range early on. Our general protocol at UCSF is kind of broken down into 6-week pieces. So the first 6 weeks is just passive range still in the sling. Second 6 weeks from 6 to 12 is starting to get some active assisted and then active exercise in there. And then 12 weeks is when we start to load it. So that first 6 weeks is much more protective, much more passive, not utilizing those muscles that have been repaired, okay? And then timeline data, what do we have on timeline data? It's not great. We have basic ideas for these timelines and common uses, but there's not great research on it, so it needs to get better. But again, talk to your surgeons, know what their protocol is, understand why they want that protocol done. If you think they can come out a little earlier, have a conversation with them, tell them why, give them good research and good evidence behind it, and then maybe you can do it. But always have that collaboration between the two of you. All right, one more case. You want to read this one?
Go ahead.
Oh, okay. All right. 20-year-old male collegiate volleyball player with a right lateral ankle pain, status post ankle inversion sprain after landing on opponent's foot under the net 3 weeks ago. How many of you guys have seen this case from a volleyball player? Yeah, it was me for a while too. So current pain is 3 out of 10 at rest with NSAIDs. Their worst pain is, again, 7 out of 10 with inversion. Affected side range actively, 5 degrees of dorsiflexion, 10 degrees of plantar flexion. And then the opposite side is going to be 35 plantar flexion. Dorsiflexion 5 degrees and passive is 10 degrees. Active plantar flexion is 35 degrees. Passive is 45 degrees. Inversion 5 and passive 10. Eversion 0 with passive 5. So they're unable to perform single leg stance due to pain and instability. They have an antalgic gait pattern with early toe off. They have moderate effusion around the lateral malleolus with yellowing ecchymosis. So brace, boot. What do you think, Tim? What should we use?
So we're already 3 weeks out, and how I guide with this kind of stuff is, can they walk normal without anything? This patient can't. There's still too much pain with full weight bearing. So I'm going to throw them in a boot for weight bearing only, just so I can get that gait pattern back a little bit better. I want them getting out, heel to toe, rolling through, starting that off. But I'm only doing it for weight bearing purposes. Anytime else, I want them out of that boot, using range of motion, moving that ankle around. Simple to bathroom and back, they can probably be without, things like that. It's just that day to day, if they have to work on their feet or something like that, put them in the boot. And then that's kind of how I guide that, is pain is my biggest guide. Because if I don't put them in a boot and they still don't use their ankle and they still don't weight bear, I'm really not helping them at all. I'd rather get them weight bearing as soon as possible with the least amount of pain, and then let pain be that guide to get them out of that boot.
And then what structures can be involved, right? So Dr. Luke did a great job of talking about some of these structures that can get involved with inversion ankle sprains. The most common thing we see is ATFL injuries, right? But we need to be aware of high ankle sprain components as well. So AITFL, things like that. Other structures that are really important for us to understand in an inversion ankle sprain is peroneal tendon. So commonly we're going to see some peroneal tendon involvement in these if they're bad enough or recurrent enough, whether it's a peroneal tendon split tear or peroneal tendinosis. So understanding that peroneal tendon and how important it is for that eversion stability, right? Providing that counter inversion. That's the thing that I'm going to be focusing on the most. So trying to get that eversion activity going so you get some more stability there, and they're not wanting to recurrently sprain the ankle because you get inhibition of that peroneal tendon, not counterbalancing it. We don't have a lot of active stability of the ankle on either side, right? But we especially don't have much active support on the lateral side. So when you lose passive stability on the lateral ankle, you don't have much option. So this is where sometimes bracing can be really helpful to allow us to get some pain reduction, some inflammation reduction, and some irritability reduction, and allow us to build that eversion strength and coordination as you're getting back into activity to try to reduce the amount of recurrence with these types of injuries.
And then as far as any progression, I would only have this patient in the boot 2 weeks maybe at most. I'm trying to get them out of this as soon as possible, and maybe in an ASO for those day-to-day then, and then be out of the ASO for anything else. So that's going to be my progression, is boot for weight bearing, nothing for anything else, ankle brace ASO for weight bearing, then nothing else, then back to full activity. And for PT, you can start it immediately. As soon as you see that patient, they should be working range of motion. As long as you're not worried about displaced fractures or complete ruptures, I mean, they're moving that ankle as much as you can. So anything in that grade 1, 2, even 2+, you're probably starting at least basic range of motion with them.
All right, we'll take questions.
And feel free to ask on any body part.
Yeah.
Going back to proprioception, thank you for sharing the study about doing exercises on a low ball and turned out to be from the hip rather than from the ankle.
Yeah.
So have you, what would be the most effective way to get distal proprioception?
Yeah.
Repair or improve?
Yeah, it's a good question. So for those of you that couldn't hear, the question was, with the study that showed more hip strategy with the Bosu ball, what would be the strategy for trying to improve distal proprioception in the ankle? So I think the first thing you have to start with is, can the muscles work effectively in the ankle, even in an open chain position? So can they do resisted eversion and inversion without a lot of pain? Because if they can't, there's no way you're going to use that ankle effectively. You're going to find other strategies to do it, and it's going to hurt. Once they can do that effectively, and I know that they can load those tendons with a minimal amount of pain, usually my cutoff's 3, then I'm going to put them into more tandem support. Maybe I'm going to give them a little bit of instability there. I'm going to start to get a little bit more dynamic with that. So I'm going to do heel raises. Heel raises, trying to work towards single leg, can improve proprioception. And then I'm going to gradually change that surface. So I'm not going to go right to a Bosu ball because it's a really hard surface to stand on. So I'm going to go to something like a foam pad, and I'm going to see how they do that. I'm going to look at them as a holistic point and say, does it look like they're more moving through their hip and kind of avoiding that ankle and falling over? Or are they able to maintain that stability, and I can see that foot moving through that inversion, eversion motion and trying to support that and trying to stabilize through that. And then from there, you can always make it a little bit more intensive. But for the majority of people, we're walking on solid surfaces. So we're not walking on Bosu balls all over the place. We don't really need that much challenge. If it's got a high-level athlete, a gymnast, something like that, then maybe you need to progress to something like that. But for most people, we just need them to have good proprioception on a stable to slightly unstable surface. You know, if they're going to Europe and they're going to walk on cobblestone, or if they're walking on the side of a hill or on a grassy or a gravelly type situation or a beach, those are where I want that activity to happen. So that's where I'm going to start to do forward back rocking over a foam pad, or start to work in that motion versus just make it as hard as possible to stand on one leg. Does that make sense? Great question. Other questions? In the back.
So the question was, for an Achilles rupture, you're putting them in a cam boot with a wedge. They're going to be non-operatively cared for. How do you know what degree? The answer is ask your MD. So we don't make that determination, or we try not to. In standard, on average, most people are in a 3-inch. Start in a 3-inch, and usually our MDs are every 2 to 4 weeks. They're going to take a full wedge out while they're doing their weight bearing, while they're doing their exercises, things of that nature, until you get them flat and then in nothing. And then when they go to a shoe, you can actually do just a small heel wedge in the shoe. Once they get out of that boot and they start to use all those muscles again, then you're not doing such a heavy load to get them started back on that. But it comes from the MD mainly because they're going to assess the angle of contracture or management that the patient is currently in and how comfortable they feel stretching that Achilles out.
All right. I think that's good.
Sorry,
back.
it's me, Danny.
Sorry.
For debate's sake, I just have a question about the 3-week out ankle sprain. How do you feel about using crutches with an ASO versus putting them in a cam boot?
Again, I'm going by pain. Can they take a good stride and load weight through that ankle in an ASO with crutches? I would rather them fully weight bear in a cam boot than partial weight bear on crutches. And there's a few reasons for that. One, you're not working gait cycle because they're on crutches. They're going to take smaller strides. Two, not a lot of people want to be in crutches. So compliance purposes, I would actually get better compliance from a straight cam boot where they feel comfortable versus crutches, period. And then 3, to me, it's more about full weight bearing than it is minor load. I'd rather get them in a full weight bear for a couple weeks and then get them in that ASO than crutches. And that's, yeah.
Yeah, I mean, I think the other piece of that too is use of hands, right? I mean, people like to use their hands. People try to get off crutches as fast as possible because they don't like not being able to carry things and use their hands to grab rails and do things like that. So I think as much as we hate cam boots from a standpoint of the secondary issues that they cause, you know, you can try to do the even up on the other side to try to reduce some of those issues. But I agree. I think as much as I like mobility and not totally stabilizing something, I do think in that case, it's a little bit better for a short period of time. Like Tim said, 2 weeks is not that much. So if it was 6 weeks in the boot versus crutches with ASO, I'd probably lean the other direction. But for a short period of time, I think it's good just to get them moving and still be able to be functional with their upper extremities as well.
And that pain tolerance is part of it too. You kind of know your patient of, is their 7 a real 7, or is their 7 most people's 2? And that's a difference that you're going to look at too. If you know it's just apprehension, maybe I'll start with the crutches, because that might prove to them, oh yeah, it doesn't hurt as bad as I thought it would. So knowing your patient helps, but for the most part, if that first pain is still a 7 with full weight bearing, I think the cam boot's going to give them a better chance to actually ambulate.
Any other questions? You're going to have to look in the back corner because I can't see. There's a post there.
Got nothing back there.
All right, cool. Well, oh, wait, we got one more. All right.
What's your opinion about icing injuries?
Oh, I have so many opinions about ice.
Do you want me to take that? You want to take that?
Why don't you take it first from an athletic training standpoint, and then I'll take it from a PT standpoint, and then we'll see where we meet.
From an athletic training standpoint, ice has a very, very limited use. Pain. That's it. It's really all you're using it for. It shouldn't be prophylactic. You shouldn't be using it just because you did exercise. Post-operatively, it's great. Biggest reason it's been shown to help reduce opioid use through pain modulation. But again, it's because the ice is being used for pain care, pain management. So if your use is pain management, I'm all for it. 20 minutes on, 2 to 3 hours off, go for it. For most uses, it's like KT tape. You are using it wrong and you don't need it. And I would suggest staying away from it as much as you can.
Yeah, I agree. So I always tell people, ice is not compression, right? And inflammation requires elevation and compression to get that lymphatic activity happening. If we're not getting the lymphatic flow, we're not getting activity and swelling, right? It is very good for some people at pain control. And then there's people that get worse using ice because it hurts, because it's cold and it doesn't feel good, right? So for me, movement, elevation, compression, those are the most important 3 things. I think it was Dr. Luke was talking about some of the acronyms that we have lately. And so in rehab, we've kind of moved from RICE to MEAT, right? So movement, exercise, analgesic, and treatment. And it takes out that ice piece. It takes out the rest word there and replaces it with movement. It replaces anti-inflammatories with analgesic medication, which I still think anti-inflammatories are okay. There's not hard research that says that the healing process is really affected by NSAIDs. So I still like NSAIDs for getting that swelling down, because the faster you can get that swelling down, the faster you can get that activation back. Swelling-based inhibition is a real big problem, and so trying to get that inflammation down is really important. So yeah, you want less pain, 100%, and there's no real risk to ice unless you stick a block of dry ice on your leg and burn yourself. But in general, I think ice is really symptom control more so than anything with swelling.
And there is a difference between ice and compression and ice.
Yeah.
So again, you need that compression to help with certain things. So if you have devices, there are things out there that can provide ice and compression, which can help with some of that lymphatic return while modulating pain. Great. But again, more times than not, it's a pain control device, not a modality that cures.
And elevation doesn't count as your foot on a chair when you're sitting, right? You got to get it above your heart. You've got to drain it back down to that lymphatic flow. For the rehab professionals in the room that have done lymphatics, make sure you're looking proximally as well and making sure everything's cleared out above so that swelling has somewhere to go, right? Can't clear traffic if the traffic's backed up in front.
For the youth athlete who you can't immobilize them because they keep doing their sport no matter what you tell them to do, or their parents, right? And they have recurrent ankle injuries. I mean, at some point, they're complaining of constant pain that they do have to be immobilized, but the other pieces, immobilize them, but do your strengthening and strengthening exercises. That's going to be pretty much the treatment plan for them.
So what I tell those parents, mostly, especially if it's a child, is how quickly do you want them to have surgery? Chronic ankle instability is a real thing. If you don't take care of it properly, they'll be loose forever and without surgical intervention. And so I'll look at them and say, you can immobilize for 2 to 4 weeks in a boot, start in an ASO and start your exercises with PT and get stronger and take 2 weeks off of that sport and likely get better. Or we'll see you next year for surgery referral because that's why that kid's ankle is hurting all the time. And so I use scare tactics with parents all the time. That's my number one go-to is how much money do you want to spend and how much complaining do you want to hear from your child when they're in a cast because they had surgery versus a boot for a couple weeks. But yes, either way, when they come back with that constant pain, if that pain's constant, I'm going to boot them and immobilize them to let everything calm down. We need it to calm down before we can actually progress through anything else.
Yeah, I mean, I think that's a whole nother talk on sports psychology and youth sports psychology and culture. I could talk about that one for a long time as I go to a travel ball tournament tomorrow. But the thing I deal with probably the most with like the Cal athletes who are young, they're independent, their parents aren't there, right? Maybe they're calling in or coming in. But for the majority of them, their parents aren't there. The biggest thing is you guys want to get back to activity. You want to get back to your sport. And if you do it too fast, it'll take you out of the season rather than let you participate in the season. If you do it correctly, we can get you back for part of that season. If you do it incorrectly, you'll hurt for half the season and be out for the rest. And so all of them are really focused on, I want to get back to doing what I need to do. I want to go back to activity. And you have to really reframe it of if you do it right, it'll happen faster than if you do it wrong. Even though you think doing this faster is going to help, it won't. Does that make sense? Yeah, it's hard. All right, thanks guys. Lunchtime.